Hello everyone, I am Varada Gosavi, roll number 51, and my topic is skeletal muscle relaxants. So I am going to cover individual skeletal muscle relaxants, their pharmacokinetics, their interactions, and centrally acting skeletal muscle relaxants and their uses. For convenience, let's call them SMR. So basically, SMRs have two major types, that are peripherally acting ones and centrally acting ones. The peripherally acting skeletal muscle relaxants have two major categories, that is neuromuscular blocking agents and directly blocking agents. The neuromuscular blocking agents can perform by two mechanisms. Those are either non-depolarizing ones or the depolarizing ones. The non-depolarizing ones are the competitive blockers. So now let's study each of them individually. The non-depolarizing ones are further classified into long-acting ones, intermediate-acting ones, and short-acting ones. The long-acting ones include the first and foremost member, that is delta tubocurarine. It was popular in the past, but nowadays it is not very frequently used because it causes significant side effects. Those are, it causes histamine release, ganglion blockade, cardiovascular block, and long-standing paralysis. The next member is pancuronium. It is a synthetic steroid and used only in long neurosurgeries. Its adverse effects are flushing, bronchospasm, and cardiac arrhythmias. Doxycurium has the least rapid onset, hence not very popular. Same goes with the pipecuronium. It has a slow onset and a long action, hence not very popular. The next category is intermediate acting drugs. It includes vecuronium. Vecuronium is excreted in the bile and neostigmine is used for its reversal after surgery. It is the common relaxant for surgery and in ICU. Next is atracurium. It is inactivated in the plasma by non-enzymatic degradation. It causes CNS toxicity if used for a longer time. Next is cisatracurium. Cisatracurium has a fewer side effects, therefore used in kidney or liver disorders. Rocuronium is alternative for tracheal intubation in the place of succinylcholine. It is used for maintenance of muscle relaxants. Succinylcholine generally causes regurgitation and high induced reflexes, and it has a very short acting time. So because of these side effects, rocuronium is used for long surgeries like neurosurgery for intubation. Now the short acting ones. It includes mevocuronium. So mevocuronium causes prolonged paralysis in pseudocholinesterase deficiency. Pseudocholinesterase deficiency is an autosomal recessive disease which causes congenital deficiency of an enzyme pseudocholinesterase, which causes prolonged paralysis. Okay, because it aggravates the effect of drug inside the blood. Now the directly acting skeletal muscle relaxants. The first one is dantrolene sodium. So dantrolene sodium resembles centrally acting SMRs. Basically it is a peripherally acting SMR. But what it is, it does not affect any neuromuscular junction. It directly dissolves inside the blood and gets to the point of action, just like centrally acting SMR. So the mode of action is, it affects RY-R1 calcium channels and prevents calcium release. So heart also has calcium channels. Why isn't heart affected by these drugs? Because heart contains RY-R2 calcium channels. So heart is safe from the action of these drugs. The actions are on two types of muscles, twitch muscles and anti-gravity muscles. Twitch muscles are greater affected by these drugs and anti-gravity muscles are mildly affected by these drugs. Its uses are 25 to 100 mg are sufficient to treat upper motor neuron disorders which include hemiplegia, paraplegia, cerebral palsy, multiple sclerosis, and it is a drug of choice for hyperthermia. So the next drug is quinine. Quinine increases the refractory period. Quinine increases the refractory period of a skeletal muscle, causing it to prolong relaxation. Now, the next category is depolarizing blockers. It includes succinylcholine. It is the most commonly used drug for passing tracheal tube in patients for artificial intubation and artificial ventilation. It should not be used in children. Its adverse effects are aspiration or regurgitation, muscle fasciculation, soreness, increase in blood pressure, increase in heart rate, arrhythmia, histamine release, potassium influx, and hyperkalemia. Next drug is dexamethasone. It is also a very popular drug used for surgical procedures. Now pharmacokinetics of SMRs. SMRs, all types of SMRs are polar quaternary compounds, hence they are lipophobic drugs. They do not cross blood-brain barrier or placenta and no oral absorption is involved. They are always administered IV or intramuscularly. Drugs are metabolized in liver and plasma and excreted by the kidney. Unchanged drug appears in urine and bile. So if we want to examine the drug levels inside an individual, we have to check the urine or we have to do the bile examination. So the short acting drugs have a very short T-half and duration of their action is 20 to 40 minutes only. Pseudocholinesterase deficiency, it is an autosomal disorder. So what does pseudocholinesterase do? It breaks succinylcholine into succinyl monocholine and further into succinic acid and choline. In absence of this enzyme, it causes prolonged phase 2 blockade that includes muscle paralysis and apnea for roughly 4 to 6 hours. Now let's study about the interactions of skeletal muscle relaxants with various drugs. So thiopental sodium, it is a systemic anesthetic. It should not be given with succinylcholine and it causes poisonous effects. General anesthetics accelerate the competitive blockers. Anticholinesterase is used after the recovery of surgery like physostigmine and neostigmine. Antibiotics such as aminoglycosides reduces the acetylcholine release. Similar effects are obtained when tetracycline, clindamycin and lincomycin are used. Calcium channel blockers enhance the action of skeletal muscle relaxants. Diuretics produce hypokalemia, hence enhance the competitive block. Diazepam, propranolol, quinidine intensify the competitive block. Now uses. These are generally used as adjuvants for general anesthesia. Also used in intubation, laryngoscopy, bronchoscopy. So succinylcholine is generally used in these sort of procedures. For assisted ventilations, we use competitive neuromuscular blockers in convulsions or trauma, and also in such disorders where aggressive skeletal muscle contraction and very emergency relaxation is obtained, we use such drugs, for example in tetanus and status epilepticus. This image is of intubation. We all know that tracheal muscles and pharyngeal muscles have a very prominent reflex mechanism. So if anything is inserted in the trachea, it causes regurgitation. So to relax those tracheal muscles, we have to use either succinylcholine or rocuronium and successful intubation is accomplished. Now centrally acting skeletal muscle relaxants. It has 4 major types: mephenson congeners, benzodiazepines, GABA mimetics and centrally acting alpha-2 agonists. Let's see each one individually. So the mephenson, second one is carisoprodol. It is a weak analgesic, antipyretic and an anticholinergic. Third one is chlorzoxazone. It has good oral tolerance. Fourth one is chloranazone. It is anti-anxiety and hypnotic drug. Fifth one is methocarbamol. It is used for orthopedic procedures and tetanus. Its adverse effects are gastric irritation and sedation. Most of the centrally acting skeletal muscle relaxants have gastric upset as a very general adverse effect. Next category is of benzodiazepines. Diazepam is used in spinal injuries, tetanus and rheumatic fever. Next category is GABA mimetic. So baclofen, it is a very common constituent of any sort of analgesic cream. So baclofen is used in spinal cord injuries. Point of application is spinal cord. So in multiple sclerosis, amyotrophic lateral sclerosis, spinal injuries and flexor spasms, its adverse effects are, as we have already seen, gastric upset and photosensitivity. Thiocolchicoside, when it is combined with NSAIDs, it is used in painful muscle spasms like torticollis, sprains and backache. The next category is central alpha-2 agonist. Tizanidine is used in multiple sclerosis, spinal injury, stroke. Its adverse effects are xerostomia, that is dry mouth and drowsiness. It is also used in insomnia and causes hallucinations. Uses of centrally acting skeletal muscle relaxants are: it is used in acute muscle spasms and also in painful conditions like torticollis, lumbago and neuralgias. The blue colored skeleton images of lumbago showing intense pain in the lumbar region. Anxiety and tension, also used in spastic neurological disease, for example in epilepsy. Also used in tetanus, electroconvulsive therapies and orthopedic manipulations. So now let's test whatever we have learned so far. The first MCQ is intubation for long lasting surgeries is done by. So, generally, succinylcholine is used for intubation, but it has a very short time of action and also causes frequent regurgitations. So, rocuronium is the choice of drug for long lasting surgeries. So, answer is B, rocuronium. Second, if thiopentone sodium and succinylcholine combination safe? So no, this combination is not at all safe because it causes poisonous effects. So it is never safe. Option B. Third one, which drug is used for reversal of skeletal muscle relaxants after surgery? So any sort of anticholinergic drugs like neostigmine or physostigmine are used after surgery for the recovery. So option C, neostigmine is correct here. Fourth question, what is the most common adverse effects of centrally acting SMR? So gastric upset, option A is the most common side effect. Fifth question, why is delta tuberculin not used? So in the past it was a popular drug, but now as people have recognized its side effect, its popularity is not so much. So what does it cause? It releases histamine, yes. It causes ganglion blockade, yes. It is long lasting in paralysis, yes. So all of the above is the option. Thank you very much.